All right, good morning. We'll be discussing the future of cranial surgery, adapting new approaches. The point of this seminar is to go over a couple of new techniques and technologies that have really changed the way we approach deep-seated complex tumors. Dr. Day is here to discuss the cannular system. I'll be discussing laser ablation. Unfortunately, Dr. Zadeh did not make it, so we will be skipping over the MR-focused ultrasound. So what is the future direction of cranial surgery? Over the last 5 or 10 years, there's been more options to treat these patients aggressively. What was once considered inoperable many times now actually becomes operable. Minimally invasive options have improved, and over time we've had better outcomes. So what are the advantages of a minimally invasive approach in cranial surgery? So just like spine, you have a smaller incision or actually no incision. Reduced wound complications, which can always be an issue when you're talking about patients getting chemotherapy and radiation. Less pain, more cosmetic, faster recovery, shorter hospital stays, less delay in any adjuvant therapy. Again, this is key when you're talking about gliomas. And then better neurological function because you're not disrupting the cortex and the deep white matter tracts. Also important to know that when you're dealing with these new techniques, patient selection is absolutely critical. These can't be applied to all cases. And just like any other new technique, there's definitely a very steep learning curve, and you got to start out with the more simple cases before you tackle some of the more complex ones. So as I said, we'll go over 2 of the 3 just because Dr. Zadeh was unable to make it. We will not be going over MR-focused ultrasound, but I'll be going over laser ablation, and then Dr. Day will be going over the BrainPath Vicor system. And then we'll close up by going over a few case examples and discuss how we would approach these and what the options are. So I think everyone here is familiar with what laser ablation is. This is a small 5-millimeter cannula which is placed deep into the tumor. And then using MR thermal therapy, you're able to cook the tumor from the inside out. You're able to very precisely control the temperature. And then over the course of just a few minutes, you're able to ablate the tissue. So what lesions do you want to use laser ablation for? What are these most appropriately applied to? So deep-seated Mets, which have failed radiotherapy, that's the #1 indication for using lit therapy. Gliomas, small focally recurrent or small focally newly diagnosed. And then also Derral-based lesions that have undergone maximal surgery, maximal radiotherapy. This is also an option. So what do we do with those deep-seated Mets that have gotten gamma knife, that have gotten whole brain, that have failed radiosurgery and have now progressed either with tumor or radiation necrosis? This occurs in about 5 to 20% of patients. Currently, there's a watch and wait model. Some people use medical therapy, Decatron, Avastin, but over the long terms, that can be pretty morbid. And then there's also surgical resection open. But however, if you look at the data, the simplest, most effective way may actually be laser ablation for these lesions. You don't have to do a repeat craniotomy. There's no wound issues. And you also avoid the long-term consequences of steroids and Avastin. So this is a case example, 75-year-old gentleman, status post-resection of a lung metastasis just anterior to the motor strip, treated with SRS, 18 grade of the cavity, does well for a year, and then a year later now has a seizure. Has an MR perfusion, which shows that it's a combination of tumor recurrence and radiation necrosis, as most of these are. So what are you going to do with this gentleman who has otherwise well-controlled disease and he's neurologically intact? Options would be to repeat another craniotomy, repeat radiation, which is not ideal. Decadron Avastin, as we discussed, can have a lot of long-term complications, or a watch and wait, which is obviously not ideal because this is growing on serial scans. So this is an ideal case for the laser. It's small, it's focal, and it's a combination of both necrosis and tumor. So this is showing how the fiber is placed, both in the sagittal and coronal planes. This was our ablation. We had 1 pullback. And then you can see here 24 hours, 2 weeks, 1 month, 2 months, 6 months, and then 12 months. You can see how the lesion is stable. And most importantly, no recurrence, no steroids, which can be very detrimental in someone who's 75 if you put them on chronic steroids. What about newly diagnosed and recurrent gliomas? So we're talking about small gliomas. These all have to be about 2.5 centimeters or less. I know that there's people out there doing much larger gliomas. Those can be much more complicated. For people who are starting to do this technique, I would certainly focus on smaller lesions that are 2.5 or less. KPS greater than 70 is absolutely critical, just like all surgical candidates. And just like open surgery, you really want to make sure you can ablate at least 3/4 of these lesions. There's really no benefit if you only resect half a glioma. There's also no benefit if you only ablate half a glioma. So you have to make sure you can ablate at least 3/4 of the lesion, and you really want to have a postoperative adjuvant therapy plan. This is key because you don't have to delay if you're going to start Avastin like you would for a normal craniotomy, usually 4 to 6 weeks. I think the real benefit in these patients, if you have a small focally recurrent glioma, is you can do laser ablation and then start Avastin within 7 to 10 days, so there's really no treatment delay. Here's an example, 42-year-old female, status post gross total resection of a GBM, left temporal lobe that was done awake, treated with Temodar, XRT, standard Stoop protocol, and then 1 year later has seizures. She then has this MRI. She's still KPS 100, and the MR perfusion shows that it is tumor recurrence. So again, what are your options here? Certainly change Temodar, go to a second-line agent like Avastin, but can you safely cytoreduce? I think the literature shows that if you can safely cytoreduce these patients prior to switching chemotherapy, that there is an advantage. So what are your options to do cytoreduction here? You can either do radiosurgery, which has been shown to really not work in terms of gliomas. You can do an open surgery. You know that this is just under Wernicke's area. There's going to be a lot of scar tissue, major morbidity, also complications with wound leaks, wound infections. So this is another great case in terms of doing the laser. You can do focal cytoreduction. You don't delay Avastin. You can start about a week later. So this just sums up what I just said. Essentially, safe cytoreduction, low risk of any kind of morbidity as long as you have your boundaries set. No wound issues. Anyone who's done these reoperative gliomas knows that these wound issues can become quite severe. So as long as you can avoid any wound issues, that's a major pro. No CSF leak. And again, no delay in chemotherapy, which is critical. So this is our laser ablation. So we came from behind. We set our temperature limits laterally, so we protected Wernicke's, and we got a good ablation. And now she's on Avastin 1 year later. Looks like there's no recurrence. Obviously, she's responded well to Avastin, but it's hard to think that cytoreduction didn't also play into the picture. And then finally, I'm going to talk about Derral-based lesions. These are small to moderately sized Derral-based lesions that have undergone maximal surgical resection. They've undergone maximal radiotherapy, and they're still progressing. And I'll show you that these are not common conditions, but you'll definitely see them in your office. These are patients who really have no other option, and this is a new therapy which can be applied. And I'll give you an example here. 62-year-old male, status post subtotal resection of a parasagittal meningioma, which is involving his superior sagittal sinus. He had a wound infection 15 years ago, cranioplasty, very complicated hospital course, and that residual on the sinus was observed. It then grew, and he underwent radiosurgery, just as we all would do, and then that was stable, and then 5 years later, now that residual, which underwent maximal radiosurgery, has also now started to grow. So what do you do with this gentleman? You can see here on the right, his scalp is just a total disaster. You can either do a repeat craniotomy, which is a large surgery. You then have to remove the cranioplasty. Repeat radiosurgery has a high risk of more radionecrosis. Chemotherapy options are pretty limited for this condition, or just watch and wait. Again, 62, healthy, neurologically intact, and it's progressing on serial scans. Also not smart to watch and wait. So this is another laser candidate. You can see here how you place the laser through the superior sagittal sinus, and you get a good ablation on both sides of the sinus. And you can see here over 2 years, this has actually decreased in size. Obviously, it's still very early. These tumors need to be followed for 10, 15, 20 years. But this is a good start, and the benefit is that even if this tumor starts to grow after laser ablation, you can then repeat the laser. So it's not like radiosurgery where you're limited. You can actually repeat the laser 5 years down the road, 10 years down the road, if there is another focal recurrence. So I think what we're seeing here in terms of the laser is just a natural evolution of how surgery has progressed. If you look at how open heart surgery was done, it all used to be done open chest, and now it's all done cardiac stenting endovascularly. If you look at how much of the GI surgery was done, much of that was done open before, and now it's nearly all done laparoscopic. Same thing goes when you're talking about open aneurysm clipping. That's certainly gotten less common, and many aneurysms now are treated endovascular. Skull base has also undergone a very similar kind of change in paradigm. A lot of the large open surgical techniques have kind of died off, and you're looking more now at radiosurgery, endoscopic approaches. And the same thing goes when you're talking about tumor resections and also epilepsy. I think a lot of the craniotomies are going to be diminished as this technology improves, as we understand how this technology works, and as we see more long-term outcomes. So with that, I'm going to turn over to J.D. Day to speak about the cannular system.